I wish to formally welcome you to the July webinar of the Paediatric Association of Nigeria. And today, the presentation will be hosted by the Society for Paediatric and Adolescent Endocrinology of Nigeria as part of the Society webinars. And the topic for today is long life management of congenital hypothyroidism. As we all know, congenital hypothyroidism is one of the conditions that we can diagnose if we do proper neonatal screening. And of course, once treatment is started early, it can change the course of the life of that child. But today, we shall listen to the experts. And our presenter for today is Dr. Ishaya Ibrahim Abok, who is a consultant pediatrician at the University of Jos Teaching Hospital. And the moderator for today is Dr. Isaac Oludare Oluwayemi, who is also a consultant pediatrician and endocrinologist at the Ekiti State University Teaching Hospital. But before the experts would make their presentation, we would like to hear a word or two from the President of the Paediatric Association of Nigeria. Madam President, if you are online, over to you. Dr. Sabansi?
Yes, sorry. I was saying thank you very much, PE. I'm online. I didn't know my mic was still muted. So, distinguished facilitators, colleagues, members of the Paediatric Association of Nigeria, our elders, and invited guests, I bring you warm greetings from the Executive Council and myself, and I welcome you to this webinar titled Lifelong Management of Congenital Hypothyroidism, Bridging Early Detection and Sustained Care. As we all know, congenital hypothyroidism remains an important childhood health condition in which early diagnosis and prompt treatment can improve outcomes significantly and also the quality of life. However, achieving optimal results requires not only timely detection, but also sustained lifelong care and follow-up. So this webinar offers an opportunity to strengthen our knowledge, share our experiences, and discuss practical strategies for improving the care of affected children in our various settings. We know that even the federal government, the Federal Ministry of Health, they are working currently to provide neonatal screening for congenital hypothyroidism amongst other childhood diseases in Nigeria. This is ongoing, so it's quite topical. And this webinar is hence very timely. So on behalf of the Executive Council and our membership, I thank our resource persons and all participants for joining us today. I encourage everyone to actively participate and make the most of this important session. And I wish us all a fruitful webinar. Good afternoon.
Thank you very much, Madam President. So I'll hand over now to Dr. Oluwayemi, who is the moderator, to kickstart this webinar. Dr. Isaac, over to you.
All right. Good afternoon, sirs and mas. Thank you very much for the privilege to host this month's edition of webinar from Paediatric and Adolescent Endocrinology of Nigeria. So today, as announced, we'll be looking at lifelong management of congenital hypothyroidism, bridging early detection and lifelong management. We know that congenital hypothyroidism is the most common preventable cause of brain damage worldwide, and accounts for 1 in 2 to 4,000 live births. And so if detected early, they have good prognosis. So this webinar is put together to sensitize us to the reality of the fact that children do have this condition and they are being managed and they do well. So wherever we are, we'll be able to pick them on time and refer them appropriately for management. To do justice to this webinar is Dr. Abok Ishaya. Is a consultant endocrinologist Jos University Hospital, and Professor of Pediatrics in College of Medicine, University of Jos. He's also the editor-in-chief, African Journal of Paediatric Endocrinology and Metabolism, and is also the Dean of Faculty of Clinical Sciences, College of Health Sciences, University of Jos. We want to please also listen patiently, and we trust that we're going to have a robust discussion that will possibly help PAN to formulate policies to move the federal government to enact the law or make our children to have prenatal screening that will help in early detection. So, Professor Abok, Ishaya, you're welcome. Thank you.
Dr. Isaac, before Professor Abok goes on, I think we'll hear a word from the president of SPAEN, Dr. Abiola Oduwole. I think she's on the call. Hello, Dr.
Yeah. Good afternoon, everybody. Sorry, my webnet is so bad. If I put on I probably will be thrown out. So good afternoon to everybody. We're so happy to have you on this webinar today. I'm looking at the numbers of the attendees and I'm actually smiling a little bit. Although I know we should be more than this, we should be in the hundreds, because what we have presented today is something that is very, very important. We're into the newborn screening, and the newborn screening, we have congenital hypothyroidism as one of the panels that we'll be screening for. And so this topic today is quite germane, because we are all pediatricians, yes, we know, but we also want you to know why it is very, very important to have the congenital hypothyroidism as part of the newborn screening. And because it will help us to appreciate the fact that even if it is just 1 in a million of all the newborn screening that is done and is discovered, all the issues that we will raise today will not happen. We have a happy child. And so it's very important for us to listen and therefore convince all of us that even if you don't have the panel, we will all start testing our newborns for the TSH and the T4. Thank you very much for listening attentively. We're very happy to present. Thank you.
Thank you, Madam President of Society of Paediatric Adolescent and Endocrinology in Nigeria, SPAEN. I like the acronym. So back to you. Sorry for the interruption, Dr. Isaac.
Thank you very much, President. Thanks for that correction. Our grammar pediatric endocrinologist, apologies for not calling earlier. Thanks for the introduction. So, Professor Abok, over to you, sir. Thank you, sir.
Good afternoon, distinguished colleagues, ladies and gentlemen. It's my pleasure to be here to discuss this very timely topic, lifelong management of congenital hypothyroidism, bridging early dictation and sustained care. I will also want to acknowledge and congratulate the new PAN president and thank the SPAEN president, Professor Abiola, for the opportunity to be able to present this topic. By way of introduction, sorry, my slide is a bit freezing. By way of introduction, I don't have any conflict of interest in this presentation. My learning objectives for today is for us to have an understanding of the natural history, pathophysiology of congenital hypothyroidism and its implication across life course, explain the principles and times of early dictation, including newborn screening strategies and their impact on neurodevelopmental outcome, and then look at evidence-based management of congenital hypothyroidism from infancy into adult who. And then fourthly, we want to look at what are the gaps in the continuity of care, such as transition challenges, adherence, and then the long-term complication. And then look at what are the barriers to access, especially diagnostic care in lower and middle income settings. I will look at it in the following steps, looking at the introduction down through the conclusion. Now, as we are all aware, congenital hypothyroidism is a dysfunction of the hypothalamic pituitary thyroid axis that usually present at birth. This causes lack of the thyroid hormone, which might present with varying severity. And that's, of course, nonetheless, is thyroid deficiency. And just a quick one, that the thyroid hormone has a very significant role in the development of the brain, in metabolic processes, and even in linear growth of the child, and even pubertal development of the child. Therefore, if you have a child who misses or who has congenital hypothyroidism, that will cause irreversible intellectual disability, which of course is preventable, and growth failure, and making it a pediatric endocrine emergency, and of course a public health issue that needs to be looked at critically and analyzed. If you look at children who present with congenital hypothyroidism, only 5 to 10% of them will have signs and symptoms at birth. Most 90%, 95% will have no clinical signs. And if there are no facilities for newborn screening, it means that these children will go undictated, and this has severe consequences on the developing brain of the child. It's been found that without screening, children who have congenital hypothyroidism have an IQ that is less than 80. 65% of them have below 85, 40% have IQ below 70, and 25% will have IQ below 55. However, in the instance where newborn screening is available and these children are picked and treatment is started within the first 1 week of life, these children have been found to have normal IQ based on study. And of course, this cost of screening is just about 0.7 to $1.6 per infant. And this has a lifelong impact on that very particular child. Now, generally or globally, it's estimated that every 1 child out of 2,000 new delivery has congenital hypothyroidism, and there's a female preponderance. And if you look at the environment, it's newborn screening. If there's newborn screening, if there's availability of newborn screening, and there's survival of preterm infant, and we're able to pick up diseases that are mild, and social demographic changes, such as if the population is a large population, all these variables will tend to affect the incidence of congenital hypothyroidism. Now, this is a global map trying to show the incidence of congenital hypothyroidism based on the different regions of the world. If you look at this very particular diagram, you will notice that the highest incidence appear to be in the Eastern Mediterranean, and the lowest appears to be in Africa. Why? I think it's because we don't know what is going on in most African countries, because we are not able to do a newborn screening. And secondly, there is also this is also a diagram trying to show the same, depict the same picture I've shown on the map. However, what is added in this is that North America, they have universal coverage. Europe has universal coverage. South America is variable. Asia is mixed. And Africa, I think it's only available in Egypt. Why is it important for us to look at Middle or Sub-Saharan Africa? Now, the global average of growth birth rate is 20. However, if you come to a country like Nigeria, you will see as high as 40, the crude birth rate, which means if you extrapolate, if 1 in every 2,000 child will have hypothyroidism, and you have like 7 million delivered births in Nigeria annually, that's you're going to be getting like 2,000 kids with congenital hypothyroidism that are missed every year. And if you multiply that by the year that Nigeria has existed, which is about 60, you're going to see that you have quite a number of kids or children that have been that have developed congenital hypothyroidism and probably intellectual disability and other comorbidities because newborn screening is not available. However, across Nigeria, there are hospital-based studies, usually small sample size in urban tertiary centers that shows various prevalence of congenital hypothyroidism. And there is no national newborn screening program at the moment, even though I know, yes, the federal government is making efforts to initiate that. So the implication of that is that most of our patients will present late with neurodevelopmental disability. Some of the clinical consequences of allowing children with congenital hypothyroidism to progress are permanent intellectual disability, motor and speech delay, sensorineural hearing, poor growth, and reduced quality of life. The economic effect is very, 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 very remarkable because for every $1 you spend, you are actually saving about $8.9 for the newborn screening. And then you're able to save so many, like the disability, the DALI, okay, you avert about $1,000 for every year without congenital hypothyroidism. What that means that newborn screening is cost effective, and it's cost effective because it saves you the need for special education, sending these children to institutional care, and then long-term health care, caregiver burden and productivity, loss of productivity in these children. Just a quick reminder here is the thyroid gland is formed from at the base of the tongue, that's by the primordial ectoderm, okay, and that formation starts at the 3rd to 4th week of life. Now, if that doesn't happen, there'll be agenesis or dysgenesis or complete hyperplasia of the thyroid gland. It's expected that from the foramen cecum, where it migrates to the tetrode, down to its current position through the hyoid larynx and then to the final position. Now, the implication of that clinically is that if there is an aberration in the migration, that will result to an ectopic thyroid. Then by week 10 to 12, thyroid hormone synthesis begin in the fetal life. Now, I won't want to, maybe just the picture is just a reminder of the hypothalamic pituitary thyroid axis, the role of TRH, anterior pituitary TSH, and thyroxine, and how it goes to the target organs and helps in brain maturity, skeletal growth, energy metabolism, and of course, hearing and cardiovascular function. That is just a reminder. However, the critical period of time when there is neuronal intense synaptogenesis, neuronal proliferation is the 2nd week of life. And this continues to the first 3 years of life when the brain continues to develop. And a very, very critical factor at this particular stage is the thyroid hormone we are talking about. So if there is absence of the thyroid hormone by the 2nd week of life, that's why it's red there, colored red, there's going to be a lot of issues that are going to spring up because of the neurodevelopmental issues, or the brain is not able to grow appropriately. Now, what are the causes of congenital hypothyroidism? Primarily, 90% of patients with congenital hypothyroidism have a problem with their thyroid gland. Either there is a dysgenesis or dyshomogenesis. Dyshomogenesis means there is the thyroid hormone synthesis pathway is defective because of enzymes, like defects in enzymes like TPO, but this usually accounts for just like 20%, 15 to 20% of the primary hypothyroidism, congenital hypothyroidism. Then just 1 to 5% might be central. And interestingly, sorry, I will need to share again, please, sorry for that. And interestingly, there are transient occasions where maternal factors such as drugs, antibodies, maternal drugs and antibodies, and iodine imbalance and prematurity even can cause transient hypothyroidism. So therefore, depending on whether it is permanent or transient, you need to follow up for like 3 years. Permanent, you need to follow up for life and take care of that child for life. Basically, this diagram also tries to look at the various causes and what happens if there is primary congenital hypothyroidism, which is like 95% of the cases. There will be reduced T4 and T3. Okay, so that is what usually happens because there's a problem with the thyroid gland. If you come to the central congenital hypothyroidism, and usually what would be reduced is the thyroid stimulating hormone is not being made available, and that will also affect the production of T4 and T3. And then transient, of course, has a similar picture with the primary congenital hypothyroidism. But irrespective of what is causing the congenital hypothyroidism, the effects on the brain, cognitive development, neuronal myelination, synapses formation will all be affected for the child. In fact, some children start developing issue even in utero. For every child that is giving birth normally, usually every child appears normal, even if the child has congenital hypothyroidism because of the maternal T4, which crosses in the placenta and provides thyroxine to the child. However, after the child is delivered, there is severance and from the maternal source of T4. And therefore, by week 1 to 4, if nothing is done, the child will develop jaundice, and this jaundice is usually prolonged. And then if it stays up to the 5th week, the child will develop constipation because of the decreased gut motility. And then because of the decreased myelination that will occur during that infancy, we'll notice neurodevelopmental delay. And then during childhood, of course, because of the effects on the skeleton, the growth will also be delayed. And if nothing, of course, the outcome is severe cognitive damage, which is irreversible. Now, each symptoms reflects a physiologic failure, and look at the timing, okay? That timing is very, very critical to the diagnosis or to the outcome of these children. How do we manage these children across life course? It is very, very important to state that for every child, the child needs a healthy mother, pregnancy for a good fetal life. So we expect that the maternal iodine status, the thyroid status should be there. In fact, if there are issues with thyroid hormone, most women will have first trimester abortion and the fetus cannot even get to time. And if the pregnancy continues, these children might end up premature. So in some environments, new screening for mothers during the first trimester is a routine part of care, either the thyroxine or the autoantibodies, or mothers who have specific risk factors like hypertension, diabetes, will be screened. Then very, very critical window, if we miss that the maternal level, is that of the newborn screening, which we all spoke about. But it's a very critical window that must be looked at. During childhood, of course, the child needs follow-up that will be done by his physician, those adjustments to support growth, to support brain development. And then adolescence is a very, very dicey period for every condition that involves any chronic condition, because at that point there is risks of poor adherence, and then there are pubertal changes that can alter the doses, and then of course transition, very critical. If we don't get it right, adulthood will be affected, and of course the next generation will be affected. So we need to screen, treat, monitor, transition, and then sustain the care for every stage matters and every patient counts. Okay. If the 5%, of course, that will present with symptoms, there are early symptoms and there are late symptoms, as I've said earlier, and some of the late features include poor growth development, developmental delay, delayed dentation, and then dry skin. And because of the effects of thyroxine on the heart and the sympathetic nerve and adrenaline, bradycardia can come in, and then myxoedema faciae can also be seen in this patient. Now, the cornerstone of prevention is newborn screening. And the aim of this is to make sure that every child that has congenital hypothyroidism it does not develop symptoms and is picked and treated appropriately so that the brain will grow well. Neonatal screening is proposed, for congenital hypothyroidism, is expected to be implemented universally. What that means is that every child, irrespective of where he or she is, should have access to newborn screening. You should be able to get that. And usually most of the screening strategies is to use TSH. Because it's highly sensitive, but there are other strategies that can be used. So primarily we use TSH from blood spot sample, and if it's elevated, the child is recalled and diagnostic testing is done. If it is normal, the child is considered okay. However, the advantage, of course, that it detects primary congenital hypothyroidism, which accounts for 95% of cases. So it makes sense, but it has a limitation because it is going to meet just those 5% of people that have central hypothyroidism. There's a strategy of using primary T4. Of course, the advantage here is that it dictates central CH, but it's limited because of the high cost. And then finally, the combined TSH and T4, which is the most highest sensitivity because it will pick both primary congenital hypothyroidism and the central congenital hypothyroidism. But of course, you expect it to be more expensive. But at the moment, we don't have any of this test going on in our community or in our practice as pediatrician. One of the most important things to the newborn screening is the timing. If you remember, I said earlier that treatment must be instituted before 30 days. So what it means is that samples must be taken 48 hours, taken after 48 hours of life, and we should be able to get the samples the result as soon as possible. And secondly, we should also avoid early sampling because of the withdrawal of maternal thyroxine. That will cause an upsurge in TSH, and that will give a false positive result. So that's why the sample has to be taken after 48 hours. However, in some at-risk patients, you need to do a repeat screening, like preterm babies, low birth weight babies, sick neonates, and even twins. Now, these children will benefit. Usually, even if it's normal, will benefit from another screening, a second test afterward. If we're able to find that, yes, the TSH and T4 are out of, with the steroids, the screening for the congenital hypothyroidism, TSH screening is elevated, we have an abnormal result, we need to do an immediate confirmatory test using TSH and free T4 or T4, depending on what is available for us. And we do not delay treatment once confirmed. Sometimes you might not even have to wait for the TSH and F34, depending on the value of the TSH you are seeing in that very particular chart. Aside doing a confirmatory test, there are other things you might also want to institute for a child with congenital hypothyroidism. Thyroid ultrasound readily available, and radionuclides and scintigraphy. And optional, of course, you might need to do genetic testing, hearing assessment, okay, so that you understand. These are some of the, if you look at this table, it gives you the cutoff of the TSH values. If you take a dry blood spot and the TSH is greater or equal to 40, you will draw sample for confirmation, and then you start levothyroxine immediately. You won't wait for the laboratory confirmation. If you use serum TSH and the sample is greater than 20 micro international units per liter, you do same as above, as the first one we have said. If the TSH is between 6 to 20, you might need to repeat the thyroid function test within the next 1 to 2 weeks. And if the serum TSH is greater than 10 after 2 weeks, that is abnormal and will require evaluation and consideration for treatment. Okay, so these are some of the key things you need to look at. What sample are you taking? What day of sampling are you looking at? That will determine what limits you're going to use for the TSH. Imaging, I've spoken about imaging, scintigraphy, I've mentioned it, and scintigraphy has supportive tools for diagnosis. And I've also said that we need to do genetic tests for some patients. If those tests are available, especially when you have a familial disease, so there's history of consanguinity, you have other syndromic features, and of course, there's recurrent congenital hypothyroidism in the family. Genetic screening is required so that you can look at the genes that help in the development of the thyroid gland, specifically, which is on my extreme left. And then that's the thyroid dysgenesis. Okay, that's the development of the thyroid, like the PAX8, the FOX1, and some. And then you can also look at the genes that are responsible for development of the enzyme that's thyroxine in the follicles, like the TPO and the TG synthesis. Can look at all those genes. Early screening matters because it helps in brain development. I think we can overemphasize that, and delayed screening will cause injury to the brain, irreversible brain injury. Of course, early treatment is also very, very important. What we need to know, which I've said, that a child is screened at birth, started on treatment. The child needs growth monitoring, developmental checkpoints, frequent pediatric follow-ups, parental health education. During adolescent, of course, they become independent and they need to be able to care for themselves. And finally, during adulthood, independent health self-management takes over, but it's initiated during the adolescent type. So that makes it from birth to adulthood, which is the lifelong conditions we're referring to. Why do we have to look at congenital hypothyroidism as a lifelong disease that requires lifelong follow-up? Because there are specific things that we need to do at specific points. For the infants, you want to avoid, prevent over and under treatment, and you want to make sure the child maintains euthyroid throughout life. Now, then you also want to make sure there is optimization of neurodevelopmental outcomes, and you want to ensure that there is normal growth and puberty, and then support this child to transit successfully. And then you want to promote adherence, and then eventually ensure that this child has the best of treatment. There are specific goals at every aspect of life. So for the neonatal period is to protect the brain. Urgent phase, high dose, 10 to 15 microgram per kg per day of levothyroxine, which is about 50 microgram per day for every newborn child. And then, of course, you have specific targets to which you should maintain. Then during late infancy, of course, you still want to maintain optimal brain development. You adjust the dose a bit downwards to 6 to 10 because you've passed the critical stage of brain development. Okay, and then during early childhood, you want to make sure that what you've started, you sustained it because it's also a critical window. By this period, the dose will have reduced to 4 to 6 microgram per kg per day. This is another diagram that looks at when you start the treatment, what do you do? You put your first follow-up 1 to 2 weeks, and you continue until TSH normalize. Then you ask the child to come every 2 weeks, and at 6 months, okay, when you normalize, you can now make it 1 to 2 months, okay? And after that, you can make the visit and the testing and the monitoring every 2 to 3 months so that you can adjust the drugs. And at 1 to 3 years, you also can make it, you can reduce the frequency. So the earlier at the neonatal period, the frequency is highest, and as the child grows older and becomes an adult, it can even be annually. And at every visit, you want to make sure you understand what the thyroid hormone status look like and how the child is developing, whether it's adhering to his medication, and if there are issues, of course, you know that you need frequent reviews. How do you understand? Yes, you want to make sure you maintain euthyroids for every patient that comes to you. To make sure the free T4 is within the upper half of the age-specific reference range, and make sure that the TH is also within age-specific normal stage. If there is high TSH, there is low free, means your child is on and has reached cognitive outcome. If you're over-treating, the TSH will be low and height-free T4 will be seen, observed. And these children have the risk of developing behavioral problem, reduced bone mineralization, and of course, craniosynostosis. which has a way of disfiguring the head of every child. One of the things you have to do during this period is growth monitoring. You take the weight, you have to take the length or the weight of the child, you have to plot it on appropriate growth chart, and you expect a normal linear growth. You expect the child to you're treating well. You expect the child to be able to attain his adult growth potential. And if that is not, what are some of the red flags that will tell you that things are not going well from growth monitoring? Poor height velocity, or you have excessive weight gain, or delayed bone age, or persistent hypothyroidism. Okay, some of these are some of the indicators from the growth monitoring. The poor height velocity, excessive weight gain, and delayed bone age signifies persistent hypothyroidism, and it's a red flag that's asks you to reevaluate the child. Of course, neurodevelopmental follow-up in congenital hypothyroidism is very, very important. You need to look at the motor development, is the language, is the child able to talk, is he able to, is he hearing very well? So you might need to do audiology testing for these children. Of course, you need to look at his cognitive performance, school achievement, and behavior, whether he's very slow, whether he's sad, and all those things will point to specific, whether you're having hyperthyroidism or hypothyroidism as we are monitoring these children. Children that are at great risk of developing poor neurodevelopmental outcomes are children who had delayed diagnosis, severe congenital hypothyroidism at birth, and of course, poor adherence by adolescent. And if you don't manage well and there's persistence of hypothyroidism, that will suggest that. So some of the developmental screening to the neurologist can be educational assessment from the teachers, visual assessment, and audiology. You can do some of those things to be able to find out if your child with congenital hypothyroidism that is on treatment is doing well. Now, during the pubertal and adolescent period, transition is very, very key. Remember, when the child is at 5 to 10, you would look at, is he progressing towards puberty? Is the growth velocity okay? And you check the bone health and psychosocial well-being. Usually, who does that? The monitoring is you, the doctor, and of course, the parent. Of course, parent tracking continue also into early adolescent. But by late adolescent, the child should be able to take care of himself and to be able to monitor some of these parameters for himself. So you have parents-led at early childhood, and during early and mid-adolescence, this responsibility is shared between the child and the parent. And as the child gets to late adolescent into young adulthood, he should be able to take care of himself, which should be patient-led care and management of congenital hypothyroidism. Now, in some instances, especially in transient congenital hypothyroidism, you need to re-evaluate the child and see if you can stop the medication. You will get some indicators that this child probably has transient congenital hypothyroidism. The thyroid gland will be there in situ when you do your imaging. The disease is usually mild, and the requirement for thyroxine is usually low. So that tells you that this is possible transient congenital hypothyroidism. And usually that is done at 3 years. Of course, it's understandable because that's the critical, at least you've exceeded the critical window of brain development. So you can take off thyroxine, wait for 4 to 6 weeks, and see how and the free T4 behave. If they are still abnormal after your withdrawal, it means you're dealing with a permanent case of congenital hypothyroidism. In adolescents, one of the major issues you would find is adherence to therapy. It's very, very common, and the reason is because of the daily medication burden. And sometimes, of course, we forgetfulness can come in. I've seen quite a number of children who say their parents didn't have money and they had to stay off their drugs for a while. Or sometimes the drugs are not even available in the pharmacy, in the hospital, in pharmacy, in town. Sometimes thyroxine will be difficult to get. And of course, misconception comes up. Patients can be told that at this stage they can take herbs or something and they stop their drug for a while. And that can cause that can be a barrier to adherence. Of course, transition to self-care. That's to adult clinic. If there is a faulty transition, these children, once they stop coming to you, they would just assume that they are fine and they won't want to go to the adult endocrinologist to continue care. So transition has to be looked at. Of course, if we educate the parents, they understand what the disease is, it will help. If we give them, of course, maybe a reminder through mobile phone to come to clinic, to take their drugs, that can help. If there are reminders also, the system, since most hospitals are using the electronic medical records, if that is integrated, that can help. And importantly, if the family-centered care approach is taken, is considered, for people who are very far, frequent follow-up can't be substitutes. For people who are very far from the health facility, the availability of telemedicine can also help with follow-up. Poor adherence, as we say, has health consequences from neurodevelopmental consequences, social consequences, even to physical growth of the child. Okay. I would skip this because I've spoken about that. Transition, of course, requires, one thing we should know, transition is a process. It's not a one-stop affair. So ideally, you should start your transition like 12 to 14 years. You should start discussing about it, asking the child, okay, at a particular time, you're going to grow, you're going to move from me to another endocrinologist. You should understand. And then, of course, in preparing for it, we have to make sure that these children understand a lot about their disease. Now, by 16 to 18, you start discussing about transfer, depending on the hospital. Some hospitals in Nigeria transfer at 14, some 16. In my center, we do that at 18. So you have to have like a checklist over time and be sure that this child is ready for transition before you transit him. Otherwise, every effort you spent in the last, let's say 18 years would be lost because of this poor transfer. And during adults follow-up, the endocrinologists will take care of that. So we should remember transition is a process. We start it gradually. We start discussing about it. We have our checklist. We make sure the child knows his medication, knows the doses, understand laboratory monitoring, what it is, and also understand the diagnosis and what is the impact on his reproductive capacity and capability. It's the same slide saying the same thing. Management during pregnancy is very critical because it can affect the fetus, and usually preconception screening should be done for pregnant women during the first trimester. And if it's identified, then these mothers can be treated. The last lab is to look at how do we improve access, continuity of care, and the future of congenital hypothyroidism care in our society. The current reality is that despite being one of the most preventable causes of intellectual disability, many children in Africa continue to be diagnosed late, and that has consequences. That includes Nigeria and other countries. Probably only Egypt has a universal newborn screening in the whole of Africa. Countries that are colored red have some facilities, yellow, have some level, depending on probably institutional base or a bit of available in a certain locality. So our problem is in Africa is to make a diagnosis. So what are the barriers that we see in early diagnosis? Of course, barriers can be looked at from the patient factor, health system factor, and policy factor. And I think where we are in Nigeria is more of a policy factor. But it's going to be very nice if patients also are aware to know that, yes, that affects them. And even though a policy is set, one of the factors that will come up from the patient factor is home deliveries, which is very high in Nigeria, because the newborn screening is hospital-based, and of course, poor health-seeking behaviors from our population, and of course, financial constraint cannot, because out-of-pocket expenditure, only 5% of Nigeria have access to any national health insurance that will take a financial burden off them. And so the health system, of course, there's no national reference lab for now that will handle such limited laboratory capacity, even though it's highly improving because point of care tests are available that we can easily do a TSH screening. Delay reporting, of course, if we come to Nigeria, reportage will be a problem. And for congenital hypothyroidism, that needs to be put in place, and our referral system. Somebody said that his problem is that they refer patients to the tertiary center. A community health worker was talking to me yesterday, and they never get to understand what is happening, whether they made the right diagnosis or whether they made the right or the wrong diagnosis. So that poor referral, two-way referral system is also a big problem. Now, for a child who is able to be picked and diagnosed of congenital hypothyroidism, there are so many issues that inhibits or stops continuity of care. We've spoken about transition, follow-up. Sometimes in Ped Endo, we have to call some of our patients to come to clinic. Poor coordination of care and monitoring gaps because of out-of-pocket expensive, irregular follow-up, so many treatment drifts. Tools also, whether the neurodevelopmental tools are available to assess all those neurodevelopmental outcomes like cognition and hearing and speech. Hearing gap is also very, adherence gap is also very, very common. And that is common with teenagers. Many people don't know that at 2 to 3 years, especially, they need to reevaluate the child to find out if the child has either persistent or permanent congenital hypothyroidism. And of course, sometimes there's lack of communication with the adult care team. Now, I'm going to give a case of a child we managed here in Jude. I think then I was still a resident doctor. The child was giving birth to 2.8 kg, was 10. This child was among the 5% that come out with clinical signs. So he had a swelling on the goiter. And because of that goiter, early suspicion of congenital hypothyroidism was made. And the thyroid function test was done, which confirmed the diagnosis. But of course, limited, we couldn't find out what was causing it. We only knew that, yes, he has congenital hypothyroidism that suggests, with a swelling that suggested dyshomogenesis. So he was started on levothyroxine during neonatal period, and initially he was being followed up adequately. So early dictation in this child was achieved. Why? Because he was among those people, 5% that had symptoms. However, he moved to a private clinic after like 2 years and continued care, and presented at 14 years when he was in GSS 2. Why? Because they noticed progressive neck swelling. He had obstructive symptoms. He had difficulty breathing, especially on exertion. When we measured his height and mid-parenteral height, we discovered that he was growing at the 50th percentile, and his parents were mid-parenteral height for him, based on his parents, was supposed to be 75, 5th and 90th percentile. So that means something happened because he has lost. There's a bit of growth compromise. However, puberty was spontaneously achieved when he presented to us. When we examined the neck, there was this diffuse anterior neck swelling. His TSH, hoarseness of voice, was also without hoarseness. Hoarseness of voice was still there, and this feature suggests hypothyroidism. And his TSH was elevated, his free T4 was low, suggesting severe primary hypothyroidism at the age of 14. This is the picture we took that day, and when we saw him and the X-ray that was done, which shows, it's not very clear, the image, that especially the X-ray, which shows tracheal compression from the goiter. So the problem with this child was of course, we said he likely has this homogenesis with poor adherence. There was increased TSH, which caused the massive goiter and airway compromise. What is the lesson from this? Early dictation was achieved, but poor adherence. When we probed, he said somebody told them they can't go on, there's a special herbs they can buy, and they've been taking that herbs for the last 1 year before representing. And that herbs was what, and then definitely they stopped their thyroxine, so leading to thyroid hyperstimulation, massive goiter, and airway compromise, poor adherence, poor knowledge, and education. So we have loss of continuity of care in this child. We had break in follow-up, and of course, because the family opted for private care, and then gradual loss of structural endocrine follow-up, which will have been available in this child. And so life course gap is there, no monitoring, no dose adjustment, no transition over that time we lost that child. And that's, of course, is a critical failure that we had in the management of this child. Early dictation saves the brain. Congenital hypothyroidism is a silent at birth and causes irreversible brain injury. Continuity of care, of course, is very critical. Non-adherence has consequences, as we've demonstrated. And health system will also determine outcome. I think if we had probably invited the child, we called, we notified them, we need to see them, the health system will have also helped in that. So what are some of the things I think we should take away from this webinar? Congenital hypothyroidism is a neonatal emergency for the developing brain. Most affected newborns appear clinically normal. Newborn screening is the most effective diagnostic strategy. Never delay treatment while awaiting imaging. And the initial dose is usually high, 10 to 15 in newborns. And you have to monitor both the thyroid function and neurodevelopmental achievement. Avoid over-treatment as well as under-treatment. We need to evaluate these children at the age when they are between 3 years and plan our transition effectively. Lifelong follow-up is very, very important. Early diagnosis and consistent care protects the brain, enable normal growth, and secure a bright future. My take-home message is in congenital hypothyroidism, the difference between normal life and lifelong complication is just the timing of diagnosis and continuity of care. Where system work, children thrive. Where they fail, the same disease leads to lifelong disability. Final call, as our president said, that of course, SPAEN is an advocacy group. And each of us is an advocate. We need to ensure that every child with congenital hypothyroidism can grow, learn, and thrive. And that is when it's dictated early, treated promptly, and we support care. So we need early dictation. We need to strengthen newborn screening. There's no two way about it. We need to treat promptly. We need to follow expertly, follow up over life, and then empower the future of every child by giving them the chance to achieve their dream. Thank you very much for listening.
Wow. Thank you very much, Dr. Abok, for that lucid presentation, pediatric friendly and easy to follow. I want to thank you for taking your time. And want to appreciate PAN for giving us this privilege to present congenital hypothyroidism. I believe we followed keenly and have questions. So I'll go to the chat box. Already people are requesting for your slides. I'm not surprised. Your slides are very beautiful. So I've assured them that it will be given to them through PAN executive. Do I have your permission, sir?
Yeah, it's okay. I think I've sent a copy to you already, so you can share with them.
Thank you very much. God bless you. So we have a question here. Please, if you have a question, please feel free to send to the chat box. Question from Dr. Ifeoma Anoche. Said, thanks for the presentation. What's your comment on routine check? Sorry. It's talking about comment on routine check for Down syndrome patients. Okay. Have you quickly answer that, sir, while we look at other comments?
Okay, so so Down syndrome patients are another target group of children that we want to screen for congenital hypothyroidism. You want to screen for thyroid disorders because children with Down syndrome are at higher risks of developing thyroid dysfunction, either hypothyroidism or hyperthyroidism. In our clinic, we have quite a number of children either on levothyroxine who are Down syndrome or on carbimazole who have hyperthyroidism. So for me in my center, we just made it a routine that every child with Down syndrome, we just asked for that as part of their care.
All right, thank you, sir. The next question, how do we screen babies given birth to at traditional birth attendants and in maternity clinic? Any experience on that, sir?
For now, there is no screening for newborn screening, but we can't, when that policy is developed, looking at the uniqueness of our community, I'm sure a policy, because it's one of the barriers I mentioned to assessing diagnostic, assessing diagnosis, okay, first for the newborn screening because of the high rate of home delivery and TBA and the traditional birth attendance at maternities or in homes. However, it's not something that can be that will be ignored when the policy is coming up, because you're going to miss out, and that will make it not to be universal. So the question is, are there things we can do? I think yes, because if there are other programs that we can write on that have been able to get TBAs, traditional birth attendants, to be trained, and especially the essential newborn care that reaches out to various areas. So as long as there is a will, I think that can be overcome. Because culturally, if you look at cultural issues, I'm not saying that home delivery is fine, but I know that cultural issues are difficult to break. And if we say we would restrict it to the hospital, then we're going to have a bit of, we're going to underscreen children. But already there are established programs that are reaching out to these people, so we can write on such programs to assess those children. Thank you.
All right,
Thank you. Just to add a bit to what you've said regarding the policy, I know that currently, PAN, we've attended 2 meetings where the policy is the process of getting the policy written and then moved on to the executive is actively on. So, the WHO has recommended that at the minimum, congenital hypothyroidism and sickle cell anemia should be screened, neonatal screening. And the Federal Ministry of Health has called several stakeholders meeting to go through the process where they are now teasing out how this screening can be done to capture all neonates. So what you're even talking about in the community, I'm sure it will also be looked at, so that you, like you said, you don't access it only at tertiary centers, equipment, medical companies that have some of these panel machines and all. So I am very positive that sooner than later, that policy we will see it, and we enjoy our pediatricians to key into it just because of these very fantastic presentations you've given. Thank you.
Thank you.
Thank you very much, ma'am. Dr. Abok, would you like to make comment on using clinical scores for early identification of signs of congenital hypothyroidism and referral to tertiary centers?
Looking at we're in developing country, clinical scores will help those people who don't have knowledge to be able to identify the 5% that will probably present with clinical features. But looking at the outcome, the outcome starts from the first 2 weeks of life. I would not want to, as a person now, to talk much on clinical the scoring system, because I think they are late sign, and there is a clinical score, of course, that exists, but it's late for me when you use clinical scoring, and you won't get what you want. I remember somebody saying even children, they are beginning to look at, especially in Europe, Quebec Hospital specifically. He said that they are trying to look at, which is also in the books, on uterine in vitro diagnosis of congenital hypothyroidism, because they have found, after following up children who were screened by the newborn, although their IQ score is normal, but it is not as optimal as children who didn't have congenital hypothyroidism. Talk more of allowing somebody to now develop clinical features before you do a clinical scoring system. So that's my take on that, Professor Isaac.
Thank you very much, sir.
Yeah.
There are no other questions in the chat box, but we have just commendation for your presentation and request for the slides. Professor Oluwayemi, President SPAEN.
Please, I have a question. I also saw it. I don't know whether you've something about it. Why is it T4 that is used? I know what they usually ask for is TSH, T3, but I'm seeing T4 here now. So, and then that's one. The second one is, sometimes you say persistent congenital hypothyroidism. I had thought that once you have hypothyroidism, it's for life. So is there a point with this sustained treatment that they will not need to take the thyroid hormone again?
Okay, I think I said there are 3 strategies to screening. The first one is using TSH, which is cheaper, which is readily available. And TSH is understandable because TSH is elevated will be elevated when the thyroid hormone is low. And considering that 95% of the congenital hypothyroids are primary, so TSH is a good indicator for screening. However, 5% of the drawback for TSH only is that you are not able to identify those who have central hypothyroidism, because if the thyroid hormone, if the pituitary is not able to make TSH will be low and appear normal. So T4 can be used in some countries, even though some countries actually use T4, but most countries are now aligning to TSH. The use of T4 for screening is to enable them to identify central hypothyroidism. The best method is actually, the third strategy is to use TSH plus T4 at the same time, so that you can pick up the central 5% and then pick up also the primary congenital hypothyroidism, which affects 95% of children with congenital hypothyroidism. I hope I've answered that question. Then the second question is, for children with transient congenital hypothyroidism, I said that usually what you look at for, there are red flags that will suggest to you that this child probably has transient congenital hypothyroidism. If it is mild, if the dose of levothyroxine you're given is low, and if the thyroid gland is well formed, there's nothing affecting the thyroid gland. You continue with the levothyroxine for these children, and at the end of 2nd to the 3rd year, you are going to do a withdrawal of thyroxine. And I said, if you do that, 3 years is indicated because the crucial brain development has at least 95 to 98% of brain growth has been achieved at that point. So you withdraw for 4 to 6 weeks the thyroxine and see if the TSH and the T4 remains normal. If they remain normal, it's transient. If they are abnormal, indicating hypothyroidism, then that means you're dealing with a permanent hypothyroidism that you need to treat for life. Thank you, ma'am.
Thank you.
Thank you very much, sir. Somebody also asked, so how do you strike a balance between over-treatment and under-treatment of congenital hypothyroidism?
Of course, that will have to do with follow-up. Because at every follow-up, even though I know that one of the issues we have is the reliability of our labs, but you have no option than to depend on the labs for TSH, T4 at every visit, especially initially, and looking at the guidelines and ensuring that your dose is within recommended period. Now, your priority within the first 6 months or the first start is, of course, is to look at T4 all through to make sure that your T4 is normal. However, changes in TSH will only occur after 6 weeks of treatment. So you look at your parameters TSH, T4, and if you're able to interpret them appropriately, you will know whether you are maintaining euthyroid state or under treating. If you notice that your TSH is going up, what it means is that you're under treating. You might need to adjust the drug. Aside from adjusting, of course, you need to ask so many questions about whether the child is actually getting the drug, whether the drug is being administered, because there's some taken with milk will reduce absorptions of the drug. You need to go all through those steps to ensure that the drug that the child is taking is available to the system. So those are some of the things. So consistent follow-up will help you to be able to balance between hypo and hyper under treatment and over treatment.
Thank you very much, Professor Abok. And that person asks, why is T3 not used for diagnosis of congenital hypothyroidism?
Okay, T3, of course, as we know, is the active form and is the one that brings most of the effect at the tissue level. And T3 is formed from T4. T3 is also account for it's just a minute quantity. I can't remember the percentage, but I know it's like 5%. I'm not too sure, 0.5% of the thyroxine. So it will not be a reliable indicator of the level of thyroxine that is in the bloodstream.
Okay, thank you, sir. Somebody's asking for a little word on subclinical hypothyroidism.
Go ahead. You can go ahead, please.
Hello?
Hello. Okay, you're asking me on subclinical hypothyroidism.
Yes, one of the participants asked.
Okay, subclinical hypothyroidism is where you have TSH levels are usually high, but T4 are usually within normal range. And from one of the tables I showed you, one of the, you look at the TSH values, if it is venous blood, if it is greater than 20 milli-international units per liter, it tells you that you're dealing with severe hypothyroidism, so you go. But if you have something, usually even though it differs with laboratory, local labs, reference range, but most of the times, if the TSH is less than 5 micro international units per liter, that will be considered normal. And any value between 5 to 10 with normal T4 will be considered subclinical. So what do you do for this patient? You wait and repeat the test maybe in the next 2 weeks to see the trajectory, because your free T4 is normal. So that means the child is not missing T4, but the TSH is going up.
All right, thank you very much. Then someone is trying to find out what our association is doing about newborn screening for congenital hypothyroidism. Please permit me to ask our president to speak to this.
Yes, I just spoke to you. That was the information I gave you. So we're working with the Federal Ministry of Health, and even somebody put in the chat box, about a meeting we had recently in June where the Federal Government of Nigeria in partnership with
Yes.
ISM Medical. So we're all there. Our own member, Dr. Ayede, is been presenting everywhere this thing. So we're advocating, like you said, and making sure that not only does it come out, but it can capture many children. PAN is seriously lending the voice, and this is part of what we're doing, sensitizing our members through these webinars on the importance of this disease, and it exists and it's preventable. So we're really trying to do our bit. I know somebody asked about cost, to reduce the cost. PAN does not pay for tests, but through our meetings, these are the ways you can influence, you can speak for the children and to the cost as these meetings evolve heading towards policy. And you can be sure we'll lend our voice towards that too. And for it to be available, because at this moment they're talking about having some regional labs, but there's going to be some referral or both way traffic so that people in the communities are also covered.
Thank you much, Ma. At this point, permit me to appreciate PAN Executive for giving us this privilege from Society of Paediatric and Adolescent Endocrinology of Nigeria to make this presentation. I want to appreciate all our participants for taking time out to participate. We appreciate all your comments on the comment box. I want to thank our president in Spain, Dr. Oluwayemi. Thank you, Ma, for your support and for encouraging us to come up with this. Maybe in 2 minutes, Ma. Final word before I hand over to PAN Executive. Dr. Oluwayemi, Ma.
Okay, thank you very much, Professor Oluwayemi and Professor Abok. You really made me very proud of you guys. And as I told you when I said this is the best time for us to have this presentation, because it just address what is going on at the present moment. And I thank the PAN executive, especially the president, who kept making sure that this presentation happened. And I'm happy that it has happened. And thank you, Professor Abok. That was very, very good, lucid PowerPoint. And no wonder everybody's requesting for it. I hope the people that will request for it will really read it and understand and enable us to have this newborn screening. Like I said, we have the 1 million, but we know we have 7 million babies that are born in Nigeria. 1 million is not enough. So we need other people to come into this newborn screening and help to at least reach, if not 50%, at least 25% of the babies that are born in the country, especially in the northern part of the country. I know in the southern part, even without this 1 million, once the health facilities catches up to this, they will begin to do it. So we need to address the north, where there's a lot of poverty, war, and all that, so as to make it happen, and so that PAN, as the forerunner for all children and adolescents, can thump their chest and say, we have done something wonderful. Thank you very much, everybody, for attending. We appreciate
you. Thank you very much, Ma. So at this point, I want to hand over to the president-elect, Dr. Eletu.
Thank you very much. And I want to lend my voice in thanking yourself as the moderator, as well as Dr. Abok, for a wonderful presentation. So on behalf of the Executive Council of PAN, I want to thank you and also thank the association, as the Society for Paediatric and Adolescent Endocrinology of Nigeria. SPAEN, well, you're not the same SPAEN that won the World Cup, so you need to be very careful. So thank you very, very much. I think this has been a wonderful presentation, and we shall share the slides since we have the permission of Dr. Abok to do so. So just before I close, I want to ask Madam President if your last words for us for this webinar. Over to you, Madam President.
Let us spread the gospel of congenital hypothyroidism. Be on the lookout for it. And anytime you're called to make any kind of contribution towards making sure that this policy is put forward, please answer us. So after that, not only the slides will be shared, but also the recording of the webinar will be shared by the secretary later on today. So we can have the whole experience again, because it's really very important. Thank you very much and have a nice rest of the day.
Thank you.
Thank you. So on behalf of the association again, I say a big thank you. God bless you all. See you next month. Bye for now.
Bye.